my name is Dr. Tammy Bailey-Stanton. I am going to be taking you through Pediatric Resuscitation Part 2. The topics that are going to be covered in this tutorial are listed on this slide. We're going to be focusing mostly on neonatal life support, looking at a little bit with regards to do with the transition from fetal circulation to neonatal circulation. We're going to look at the neonatal resuscitation algorithm, the different steps that need to be taken as part of a neonatal resuscitation, including cord management, oxygen toxicity, and some of the reversible causes. The 2020 ILCOR guidelines on neonatal life support are 37 pages long. The executive summary is 26 pages long, with 2 pages dedicated to neonatal life support. The whole aim of neonatal resuscitation is to help the newborn transition from fetal circulation to newborn circulation. The picture on the left demonstrates the fetal circulation in utero. There are a number of shunts that enable oxygenation of tissues and supply of blood to the fetus. The picture on the right demonstrates neonatal circulation. And it is this transition that occurs from fetal to neonatal circulation. Part of it is when the infant takes the first breath. The next video is going to demonstrate the transition and the changes that occur at birth and the neonatal circulation that ensues.
Fetal Circulation by Lisa McCabe.
Hello, my name is Lisa McCabe. I'm a clinical nurse specialist at Children's Hospital Boston in the cardiovascular program. We are now going to talk about fetal circulation and the transition to postnatal circulation that occurs after birth. The specific structures associated with fetal circulation include the placenta, the umbilical vein, the ductus venosus, the foramen ovale, the ductus arteriosus, and the umbilical arteries. Blood rich in nutrients and oxygen supplied via the placenta flows through the umbilical vein to the ductus venosus. Blood flows from the ductus venosus into the inferior vena cava up to the right atrium. This blood mixes with blood returning to the heart from the upper body via the superior vena cava and from the lower body via the inferior vena cava. Once in the right atrium, some of the blood flows to the right ventricle and some of the blood flows through the foramen ovale to the left atrium and into the left ventricle, where it is then pumped out into the aorta to the body.
Point of clarification. The flow of blood from the right atrium to the left atrium via the foramen ovale enables oxygenated blood from the placenta to reach the coronary arteries and cerebral circulation, the two most metabolic active organs in the developing fetus.
Blood that flows into the right ventricle is then pumped into the pulmonary artery. Because the lungs are fluid-filled instead of air-filled, the vessels in the lungs are narrow, creating higher resistance to blood flow into the lungs. Due to this high resistance to blood flow in the pulmonary circulation and the low resistance to blood flow in the systemic circulation, blood pumped into the pulmonary artery by the right ventricle is more likely to flow into the ductus arteriosus and then into the aorta. Due to the high blood flow from the superior vena cava and the inferior vena cava up to the right atrium, pressures in the right atrium are higher than in the left atrium. This promotes blood flow through the foramen ovale at the atrial level. Only 8% of right ventricular output flows into the lungs, providing nutrients for the developing lung tissues. Most of the blood passes through the ductus arteriosus into the aorta and out to the body. The umbilical arteries allow blood to flow from the body back to the placenta to be enriched with oxygen and nutrients. Once the baby is born and takes a breath, the umbilical cord is clamped and the placenta is removed from the systemic circulation. Immediately, the transition from fetal to postnatal circulation begins. With the elimination of the placenta from the circulation, systemic vascular resistance begins to rise. With each breath, more alveoli in the lungs expand and the vessels surrounding them dilate in response to the presence of oxygen. Pulmonary pressures begin to decrease. Although pulmonary pressures are lower than systemic pressures within minutes after birth, it is 6 to 8 weeks before pulmonary vascular resistance decreases to normal. In the postnatal circulation, blood no longer flows through the foraminal valley or the ductus arteriosus. The increase in left atrial pressure after birth forces the septum primum against the septum secundum, functionally closing the foraminal valley. Within 3 months, the foraminal valley permanently closes as fibrin deposits fuse the layers of septal wall together.
Point of clarification. While the patent foramen ovale, or PFO, may close by this time, it also may not. Autopsy studies in adults indicate that 15 to 25% of adults have a patent foramen ovale, which never close. The shunt via the PFO after birth is usually small.
The ductus arteriosus begins to close shortly after birth, once the infant begins to breathe. Normally, the ductus closes completely in 4 to 10 days. The ductus venosus is open at the time of birth, making central venous access possible through the umbilical vein. As fibrin infiltrates the ductus venosus, it usually closes within 3 to 7 days. After it closes, the remnant is known as ligamentum venosum. Within a week after birth, the umbilical vein and umbilical arteries are infiltrated with fibrin and also become ligaments. Thank you for your time. This concludes our lecture on fetal circulation.
Please help us improve the content by providing us with some feedback.
This diagram demonstrates the typical flow of a neonatal resuscitation process. Most newborns respond to minimally invasive measures to support their transition from fetal circulation at birth. 80 to 85% of neonates breathe spontaneously within the first 30 to 60 seconds without any interventions. A further 10% of newborns respond to the simple measures of warming, positioning, opening the airway, and stimulation. 5% of neonates require positive pressure ventilation. Much less than 2% require invasive airway maneuvers, such as intubation. Hardly any newborns require chest compressions and medications like adrenaline. All healthcare providers attending to births need to be prepared. This means making sure that we have neonatal resuscitation equipment, as well as a maternity pack with delivery items as well. It's best to prepare the environment to keep it as warm as possible and have clean, dry, warm blankets or sheets if possible, and to maintain our skill as healthcare providers. When preparing for a birth, it's really important to get as much information as is possible from the mom. So we can do that by asking her questions and also having a look at her antenatal card. Is she booked? Does she actually have an antenatal card? We need to find out, is this a term baby or is this a premature baby? And we do that by having a look at the gestation. When was her last normal menstrual period? And when is her estimated date of delivery? What is her gravidity and what is the parity? So gravidity is the number of previous pregnancies. Parity is the number of times that she's given birth to a viable fetus, and that means more than 24 weeks. Does she have pre-existing medical conditions? Does she have pregnancy-related conditions? For example, does she have chronic hypertension or preeclampsia? Does she suffer from diabetes mellitus or gestational diabetes? Is she taking treatment for HIV? The reason we're asking these questions, we're trying to figure out, is this a high-risk pregnancy or is it a low-risk pregnancy? Because that implies that this could be risky for the infant, or are we going to have smooth sailing? We also need to find out, has she had problems in her previous pregnancies and problems in this pregnancy? With regards to her current situation, is she having PV bleeding? Has she spontaneously ruptured her membranes? When was the last time she felt fetal movements? And is she in labor? Is she feeling contractions? With regards to the contractions, what exactly is the timing in between the contractions? So what are the intervals? This is a table taken from the European Resuscitation Council 2021 Guidelines on Newborn Resuscitation. There's a number of factors, both intrapartum, which means during the delivery, and antepartum, which means during pregnancy, that may lead to an increased risk. These factors might contribute to the neonate needing resuscitation and needing further stabilization. I'm going to leave it up a minute for you guys to have a look. And you'll see why it's important to ask a history of the birth and an antenatal history from the mum. There are a number of ways that a newborn can lose heat: by radiation, conduction, evaporation, and convection. It's this reason that thermoregulation is vital in the resuscitation process. Thermoregulation is one of the most important things for resuscitation of a newborn. The ambient temperature in labor ward, theatre, and the nursery can be carefully regulated. Any delivery suite, including in the emergency department, needs to have a radiant warmer in preparation for newborns. The radiant warmer has a small bed with safety sides. It has heating above the baby, oxygen, monitors, including temperature monitoring of the infant. While labor ward and nursery are very well controlled environments, delivery of a baby in the pre-hospital environment can be unpredictable. You may deliver in the patient's home. The patient may deliver in a taxi on the way to the hospital. The patient may deliver in the bathroom. The next video is of a delivery by an EMS fire service. While delivering in the back of an ambulance is a fairly common occurrence in our environment, apparently this team had not delivered a baby for 16 years.
All right. Relax. Hang on. Push. Push. Come on, we gotta push. Yeah. We need you to push. She's right there. She's right here. Push. Hike the leg up. Push. Push. Right there. Please. Push. Yeah, push. Don't push. Drink your butt. Push. I know. Push. Push, please. You're doing it, Chris. You're right. Just take the leg back. Push, please, push. Whoa, push. We got Airway. Push. Don't touch that. Push. I'm trying to get the head up.
She out? Really? Oh my lord. got a baby, man. Thank you. Let me see her.
Sir, relax for a minute, okay?
Despite the chaos, the bumpy ride, and blaring sirens, this video and subsequent photograph was posted on YouTube by a very proud new dad. One thing that I think you can take out of this is don't ever underestimate the importance of sharing in the birth of a newborn. Don't underestimate the valuable role that you have in ensuring that the newborn transitions quickly and safely. Much like there being many adult and pediatric cardiac arrest algorithms, there are also numerous different neonatal algorithms. The algorithm on the left is the 2020 ILCOR neonatal resuscitation algorithm. The reason this is interesting is because ILCOR doesn't usually release algorithms. They usually release guidelines, science reviews, but they don't usually put information or science into an algorithm form. The algorithm on the right is the 2020 AHA algorithm. The algorithm on the left is from the European Resuscitation Council. Much like the pediatric resuscitation algorithm from the same council, this algorithm emphasizes the provision of 5 assisted ventilations early in the resuscitation process. The algorithm on the right is off Twitter from Sarah Fourie. She attended a neonatal resuscitation program and put her learning into a flowchart as well. This is the newborn resus algorithm from the Resuscitation Council of Southern Africa. It was released in 2021, so it's fairly new. It's very similar in many ways to the previous algorithms. Please take time to familiarize yourself with the content of this flowchart. We're going to walk through this algorithm whilst discussing various aspects of newborn resus. The concept of the golden minute in newborn resuscitation is fairly universal. These are the initial steps that need to be taken in the first minute after the birth of the baby to support the newborn. Usually only minimal actions have to be taken during this period. Part of the initial assessment is to decide, is this a term gestation? Is the baby breathing? And is there good tone? The first priority is to warm the baby. We need to provide a warm environment, have warm, dry blankets ready, and as soon as the little one is born, pop the baby onto mum's chest for some good skin-to-skin warming. This is also known as kangaroo mother care. KMC has many benefits, particularly for infants with low birth weight, but there are benefits for all births. Infants who receive KMC after stabilization have a 40% lower mortality than those who receive conventional care in an incubator or radiant warmer. There's less hypothermia, fewer infections, higher rates of exclusive breastfeeding, decreased hypoglycemia, better weight gain, decreased need for respiratory support, antibiotics, and intravenous fluids. There's improved physiological transition, better bonding between mum and babe, and earlier hospital discharge. I'm sure you'll agree that these benefits are great when it comes to little ones. Clearing the airway, if necessary, is important in the delivery. However, this does not mean suctioning. So routine suctioning is not part of the initial assessment in the golden minute. We can clear the secretions by wiping the baby's face, wiping the nose, wiping the mouth with a sheet or a towel that we've received the baby in. If you do have to suction the nose, using a bulb suction is much better than using long suction tubing. The reason for this is long suction tubing can result in vagal stimulation, especially if it's very lengthy, can also result in bradycardia and hypoxemia. For many years, it was the practice for a non-vigorous meconium-stained newborn to be intubated and suctioned at delivery. A meconium aspirator could be used in order to remove the meconium-stained liquor, especially if it was thick meconium, from the airway. The most recent guidelines, 2020 and 21 guidelines, recommend that this is not good practice, that routine intubation and immediate suctioning of non-vigorous newborns is not recommended. The reason for this is that the intubation and suctioning process delays ventilations, and what is life-saving for non-vigorous infants is bag mask ventilation. If it's a premature infant, so teeny tiny, less than 30 to 32 weeks, thermoregulation is really important. It's very easy for these little ones to lose heat, so they are popped into a plastic wrap, a sandwich bag, a plastic packet, to enable them to retain fluid and retain warmth. And this is recommended for premature babies. If it is a term pregnancy, more than 32 weeks, then it's routine within the golden minute to dry and stimulate and warm the baby. It is no longer recommended that the umbilical cord is cut at the time of delivery. We now need to be advocates for delayed cord clamping, and the management of the cord needs to be delayed for at least 1 minute, for at least the duration of the golden minute. The American College of Obstetricians and Gynecologists recommends the delay of cord clamping for 1 minute, whereas the WHO recommends delayed cord clamping for 1 to 3 minutes. The NICE guidelines recommend delayed cord clamping for 1 to 5 minutes. You'll see that there is definitely a move away from immediate cord management to delayed cord management because it's incredibly beneficial. We need to become advocates for delayed cord clamping. There are benefits for both the term and premature infant. For the term infant who has delayed cord management, they have found that there's increased hemoglobin and improved iron stores, which may improve the development of the child. In preterm infants, there's even more reason to delay cord management. The benefits are improved transitional circulation, a better establishment of red blood cell volume, the decreased need for transfusion, decreased incidence of necrotizing enterocolitis and intraventricular hemorrhage. These are life-threatening conditions that can occur, particularly in preterm infants. So the current recommendation is if the infant is born and is vigorous, we are not worried that we have to necessarily do any specific interventions to resuscitate the infant. It is advised to delay cord clamping as long as possible, so that all the benefits of delayed cord clamping can be met. However, if resuscitation is required, we still mustn't cut the cord as the first thing. We must still follow the initial steps to dry, warm, and stimulate the newborn. If possible, we need to try and do the initial parts of the resuscitation, if the newborn requires resuscitation, on the mum's chest. However, if further interventions, for example, bag mask ventilation, need to take place, or CPR compressions, space might then become an issue. So then it is advised that we cut the cord so that we can resuscitate the infant apart from the mum without the space restraints because of the umbilical cord. One of the things to note about delayed cord clamping is that it does not increase the risk of postpartum hemorrhage for the mum. Delayed cord management is purely beneficial. A floppy newborn may be suffering from neonatal asphyxia. It used to be recommended that early cord clamping was the thing to do with birth asphyxiated neonates. The reason for this is they needed to be resuscitated quickly. The problem is that when there's birth asphyxia, frequently there's decreased circulation and decreased perfusion, which leads to ischemia and ischemic reperfusion injury. Delaying cord clamping can be one of the things that can be done to mitigate it. However, if the cord is clamped early, there can be worse ischemia reperfusion injury. The problem with clamping the cord early is that 30% of the fetoplacental blood volume is then discarded in the placenta. This means that there is decreased blood supply and decreased perfusion to the brain. If the neonate has any reason to have lost blood for any other reason, so if there's pre-existing neonatal hypovolemia, this can further decrease the left ventricular load. All of these risk factors lead to decreased perfusion to the brain, cerebral hyperperfusion, and hypoxic ischemic encephalopathy. If we've thrown away a large portion of the blood in the placenta, then we've got a decreased red blood cell volume and a decreased oxygen carrying capacity. This means less oxygen and blood supply to the tissues, and all of this results in oxidative stress. These factors, along with an impaired pulmonary vasodilatation at birth, lead to the increased risk of persistent pulmonary hypertension of the newborn and hypoxic respiratory failure. So by delaying cord clamping, we get the benefit of having the blood volume, we decrease the reperfusion ischemia injury, we decrease the risk of cerebral hyperperfusion and hypoxic ischemic encephalopathy. Delayed cord clamping may be neuroprotective. Delayed cord clamping also facilitates the cardiovascular transition for the non-vigorous neonate at birth. So although we do want to resuscitate these newborns really quickly, it is recommended that at least for the first minute you don't clamp the cord. Still do the usual steps that we need to do before clamping the cord and continuing with the resuscitation process. So we've managed to go through the first part of the golden minute, and now we've reached this part where we are now going to assess whether there's crying, is the little one breathing, and what is the heart rate. So if the child is apneic, or if there's gasping, or if when we feel the heart rate or listen to the heart rate, it's less than 100, then we need to move on with the rest of our resuscitation. The best way to find the heart rate is to palpate at the base of the umbilicus, where you can feel the umbilical pulsations at the same time as auscultating over the precordium, usually for 6 seconds, and then times your result by 10 to get the heart rate. We then need to open the airway of the neonate into the correct position, which is the sniffing position, and provide positive pressure ventilations. Initially, we start with room air, 1 breath every 2 to 3 seconds, which leads to a respiratory rate of about 30 to 40 breaths per minute. The next step is to start positive pressure ventilation. You need to assess the chest rise with each breath that is delivered. If you're not getting adequate chest rise, you need to reposition the airway and ensure that you've opened the airway in order to provide breaths. It's not important how you give the positive pressure ventilation, whether it is with a self-inflating bag or a T-piece resuscitator, commonly found in a neonatal ICU setting or transport setting, or if you're working in theatre and you've got a flow inflating bag. There's a very small amount of evidence supporting the use of a T-piece resuscitator, for example, Neopuff, that there might be an increased survival, decreased bronchopulmonary dysplasia, and decreased intubation rates if we use the T-piece resuscitator. However, the evidence is so small at this stage in 2020, ILCOR cannot recommend the use of one device over the other. The importance is starting ventilations and giving the positive pressure ventilation. PEEP is beneficial, especially for the premature newborn, and a PEEP of 5 is considered safe. So you need to add a PEEP valve if you're using a self-inflating bag, or set the PEEP up to a level of 5 if you're using a Neopuff T-piece resuscitator. Some people might use a sustained inflation as a way to recruit the newborn's lungs, it is not recommended to use a sustained inflation of more than 5 seconds, especially with premature newborns. At this point, it's really important to pop on a SATS probe, and if you have possibly ECG leads, also to place those. We like to place the SATS probe preductal, which means before the ductus arteriosus, and this means either on the right ear or the right hand side of the body, because the SATs on this side will usually be higher. All neonatal resuscitations, you need to start with ventilations on room air. We can increase the oxygen as needed. There's evidence to support that the initial resuscitation of newborns is done with room air. There's actually a mortality benefit. There's a 27% relative survival benefit and a 4.6 absolute survival benefit when newborns are resuscitated with room air as opposed to 100% oxygen. So start low, monitor the SATs, and increase as needed, bearing in mind that the anticipated SATs of a newborn is not above 90. The SATs of a newborn slowly rise within the first few minutes to the first 10 minutes. If it's a premature newborn, make sure to use an oxygen blender and use up to a concentration of 30% of oxygen. We've got to be really careful of hypoxia in preemies. Avoid high concentrations. So the way that we can bag with room air is not connecting to oxygen. If you connect the bag, the BVM, to oxygen, that's providing about 40% oxygen. And if you add a reservoir bag, we can pretty much, with a good seal of a face mask, get all the way up to 100% oxygen. So the trick is not to add a reservoir bag for a small a newborn. Preterm newborn infants are particularly vulnerable to oxidative stress because they've got a decreased antioxidant defense and frequent exposure to oxygen during their resuscitation and stabilization process. So there's many common preterm morbidities that are directly associated with oxygen toxicity. For example, bronchopulmonary dysplasia, retinopathy of prematurity, intraventricular hemorrhage, and those are all bad. So it's really important for clinicians to prevent hypoxia because it's harmful. While we're trying to prevent hypoxia and provide oxygen and ventilation to little ones, we need to make sure that we're also preventing oxygen toxicity, especially in neonates and particularly in premature neonates. Each step of the algorithm requires about 30 to 60 seconds for interventions to be undertaken before moving on to the next part of the algorithm or resuscitation. If after 30 to 60 seconds of good ventilation, we are not getting a response and the heart rate is not picking up and still remains less than 100, or the little one is not picking up and the respiratory effort is still poor, then we need to add oxygen. Coming back to our algorithm, we'll see that we've just reached this part where we need to ventilate with supplemental oxygen. While we are ventilating with supplemental oxygen, we need to assess the response of the newborn. We need to look at their heart rate, their breathing, their SATs, and their color, and do assessments every 30 to 60 seconds. You'll notice that on the right-hand side of the algorithm, there's a box which includes the normal preductal SATs that's expected after birth. At 1 minute of life, the SATs of a baby on pulse oximetry are only about 60%, so don't expect really high SATs. Round about minute 5, we've only then reached SATs of about 80%, and we don't reach SATs of 90 until at least 10 minutes after birth. So just because the pulse oximetry SATs are still low during the resuscitation, this is not an indicator to increase the oxygen concentration to a high flow or a high oxygen concentration. This is normal and it's part of the transition process. It is expected. So while we're bagging with oxygen, then we need to reassess. If the heart rate on reassessment is above 60, then we just need to continue with supplemental oxygen and possibly supplemental ventilation. After 60 seconds of good ventilations with oxygen, we need to assess the infant. Is the little one floppy? Is it apneic? Is there gasping? And we feel the heart rate. If the heart rate is less than 60, this is the trigger for us to move on with the algorithm. So we've reached this part of our algorithm where if the heart rate is less than 60, we need to carry on ventilating but take further steps. We need to consider intubation. If you're skilled and are able to place an advanced airway, this is an option. However, if you're getting great chest rise with each bag mask ventilation, it only has to be a consideration. We do, however, have to start compressions. So compressions is what's going to help us elevate the heart rate above 60 because this child is peri arrest. We need to start chest compressions that are coordinated with the ventilations. So a compression to breath ratio of 3 compressions to 1 breath, and each cycle should take 2 seconds. This looks like compressions at the rate of 1, 2, 3, breathe, 1, 2, 3, breathe. And this results in a compression ventilation ratio of 90 compressions and 30 breaths per minute. We suggest that chest compressions in the newborn infant should be delivered by the 2-thumb hand encircling the chest method as the preferred option. Evidence shows that there's benefit to this because it can generate higher blood pressures, there's less provider fatigue, and it's more consistent, as in there's less variability when compressions are provided in this manner. Advanced airway maneuvers may include intubation with an endotracheal tube or the placement of a supraglottic device if endotracheal tube placement is unsuccessful, for example, placing an LMA or a laryngeal tube. So coming back to our algorithm, we have continued to ventilate with supplemental oxygen. We've considered intubation or even placed an advanced airway. We're doing CPR and we're optimizing our ventilation. So 3 compressions to every breath. We've done adequate ventilations, good CPR. Each cycle is taking 2 seconds. Then after 30 to 60 seconds of this intervention, we need to reassess the neonate, have a look at the heart rate, have a look at the breathing, has the SATs improved, has the color pinked up, and are we getting a response to our resuscitation? If the heart rate remains less than 60, then we need to continue with our resuscitation, which is involving this part of the algorithm. However, if the heart rate is above 60, we very well might need to stop compressions and then just continue with ventilations. The next part, I'm going to go through the steps in the last part of the algorithm, which are interventions which are not frequently needed in neonatal resuscitation. If you haven't managed to get intravenous access yet as part of the resuscitation, now is the time. It is recommended that umbilical venous catheterization is the primary method of vascular access during newborn infant resuscitation. If the umbilical venous route is not feasible, it is very frequently difficult to place a peripheral venous line. So if this is the case, then an intra-RCS route is also reasonable as an alternative vascular access for the newborn. First option, umbilical vein. Second prize, intra-RCS. Just a reminder that when you're looking at the umbilicus, you need to make sure that you've cut it long enough. You need to allow at least up to about 10 centimeters. When you're looking at the umbilical cord, please remember that there's 2 arteries that are small with thick walls, and the vein is larger and compressible. Teeny tiny babies need teeny tiny doses of adrenaline. We can't give the same dose that we give an adult patient, so we can't give 1 milligram of adrenaline. So we need to prepare the adrenaline. 1 milligram of adrenaline, which is 1 ml, is added to 9 ml of normal saline or water for injection. This results in a solution of 1 in 10,000 or 100 micrograms per ml. Adrenaline is recommended for persistent heart rate of less than 60 minutes despite optimal ventilation and optimal compressions. The The dose of adrenaline is best given via the intravascular route, whether that be intraosseous or umbilical vein catheter. The dose is 0.01 milligrams per kg as the starting dose, which is 0.1 mil per kg of a 1 in 10,000 solution. It is best to give intravenous or intraosseous adrenaline. However, if you don't yet have venous access, the endotracheal route can be used. It is a higher dose than that is required, 0.5 to 1 mil per kg of that 1 in 10,000 solution, because the uptake of adrenaline from the lungs is much less. So then you need to squeeze the dose down the ET tube and bag it into the lungs. The administration of endotracheal adrenaline mustn't delay attempts to establish vascular access, because vascular access is more important. If the response of endotracheal adrenaline is inadequate, as soon as intravenous access route is established, then we need to give the intravascular dose, regardless of the interval between the endotracheal dose and placement of the venous line. Further doses of adrenaline can be given every 3 to 5 minutes. You'll see in the ILCOR guidelines that they can actually recommend a dose of 0.01 to 0.03, which is 0.1 to 0.3 mils per kg. And the reason for this is the evidence for dosing in neonates is not very good. There are not many medications that are important during neonatal resuscitation. We might have to administer adrenaline, but checking an HGT is an important part of the resuscitation. Neonatal hypoglycemia is defined as an HGT of less than 2.6 millimoles per liter. An intravenous glucose infusion should be considered as soon as possible after resuscitation, with the goal of avoiding hypoglycemia. If we find that there is an existing hypoglycemia, it is best to give intravenous dextrose. We can either give a dose of 2 to 4 mils per kg of a 10% dextrose solution, intravenous or intraosseous. If it is a preterm or low birth weight, we'll start on the lower end, 2, and then repeat doses as required. If it is a full term or a good weight baby, we'll start with 4 mils per kg. If you do not have access to a 10% dextrose solution, we can use a 12.5% dextrose solution as discussed in our previous tutorial, and then use 4 mils per kg of that solution. The best way to treat hypoglycemia in a vigorous infant is with breastfeeding. If you have an infant, however, who is drowsy or floppy, and you are unable to get intravenous or intraosseous access, it is an option to give sublingual dextrose. So if you have dextrose gel, this you can rub into the cheeks and under the tongue. First, you need to clean the inside of the mouth, make sure that it is dry before rubbing in with a gloved finger. So 0.5 mils per kg of a 40% dextrose solution is what is recommended in literature. It's not advised to give 50% dextrose orally because it can cause vomiting. And the difference between rubbing the dextrose into the cheeks and under the tongue is that this dextrose is going to be absorbed via the capillaries, and it is not actually oral administration, so we don't require the child to actually feed. If you've got a vigorous child who still has persistent hypoglycemia, if the mum is able to express, we can add 50% dextrose, so 5 mils of that to each 10 mils per kg of feed, or add 5 mils, which is 1 teaspoon of sugar, to expressed bread, breast milk, or feed. Routine boluses of intravenous or intraosseous fluid is not recommended. However, if there is obvious blood loss then from the neonate, then it is recommended to replace that volume either with red blood cells, so a blood transfusion, or with a bolus of crystalloid. There's no evidence to support the routine use of boluses of volume in the newborn infant where there's no obvious blood loss. The problem is that we're not sure if there could be internal hemorrhage or intracranial hemorrhage. So if there's occult blood loss or suspicion for occult blood loss, you can give a trial of volume administration. So a bolus of 10 mils per kg is recommended. Much like any other resus, we need to still think about our reversible causes and go through relevant H's and T's. However, in a neonate, the most important reversible causes are hypoxia and hypothermia. As mentioned, hypovolemia is not a big cause in the newborn infant unless we're expecting internal bleeding. Toxins might be something that we have to consider. However, our first priority is resuscitation. The toxins that might be on board might be if the mum has received opioid medications just prior to the delivery. It is not recommended to give routine doses of naloxone on delivery of the baby. The first priority is always ventilations and adequate ventilations and compressions if necessary. If the mum, however, has delivered in a hospital or in the labor ward and she has just received an opioid medication, the ERC 2021 neonatal guidelines recommend a dose of 200 micrograms of intramuscular naloxone can be safely administered. However, we must carefully monitor the neonate for ongoing respiratory depression. At each step of the algorithm, you need to make sure that the ventilations are adequate. There is a cool mnemonic, if you're a mnemonics person, called Mr. SOPA that will take us through the steps to optimize our ventilatory efforts. Adjusting the mask and making sure that if it is a difficult ventilation, we're considering a two-hand technique, even in a neonate. Repositioning the airway, making the head neutral, potentially putting a towel underneath their shoulders because the occiput is large. So each of these steps need to be taken. If the ventilations are not adequate, compressions are not enough to resuscitate the neonate. We can suction the mouth and nose using a bulb suction, and if you have to, a suction catheter. Open the mouth, considering with a jaw lift movement. Increasing the positive pressure, so trying to increase the positive pressure from 5 to 10 centimeters of water with a maximum of 40. This is a little bit more easily done if you've got a T-piece resuscitator and you can control the pressure that is delivered. However, it does mean that you can increase your efforts if you're using a BVM. And as a last resort, we can try an alternative airway. Endotracheal intubation is an advanced airway skill, and if you're able to do it, this is probably the best way to deliver good positive pressure ventilations to the lungs. If an endotracheal tube is unsuccessful, you can place a supraglottic airway device, so an LMA or a laryngeal tube. Coming towards the end of our resuscitation, we need to look at post-resuscitation care. This includes targeted temperature management, looking at ongoing respiratory support, and the administration of surfactant. Newborn infants who breathe spontaneously need to establish a functional residual capacity at birth. Some newborns may experience respiratory distress, which manifests as labored breathing or persistent cyanosis. Continuous positive airway pressure, it's a form of respiratory support, can help prevent atelectasis in the newborn. CPAP is especially helpful for preterm newborn infants with breathing difficulties after birth or after resuscitation. CPAP may also reduce the risk of death or bronchopulmonary dysplasia in very preterm infants when compared to endotracheal intubation and positive pressure ventilation. It's a much less invasive form of respiratory support and less invasive than intubation and invasive positive pressure ventilation.
This video demonstrates administration of CPAP as part of delivery room resuscitation. CPAP stands for Continuous Positive Airway Pressure. The baby receiving CPAP must be breathing spontaneously and have a sustained heart rate over 100 beats per minute. CPAP uses continuous low gas pressure to keep a breathing baby's lungs slightly inflated at the end of exhalation. It may be helpful when a newborn has labored respirations or low oxygen saturation. CPAP may be helpful for preterm babies whose lungs are surfactant deficient, causing the alveoli to collapse at the end of each breath. When CPAP is provided, the baby does not have to work as hard to reinflate the lungs with each breath. Using early CPAP may avoid the need for intubation and mechanical ventilation. This newborn has grunting respirations and requires free-flow oxygen to maintain oxygen saturation within target range. This oxygen is being delivered from the tail of a self-inflating bag. However, CPAP cannot be administered with a self-inflating bag. Use a T-piece resuscitator or a flow-inflating bag to deliver CPAP. To prepare the T-piece for CPAP, occlude the mask and adjust the PEEP cap so the manometer reads 5 centimeters water pressure. To prepare the flow-inflating bag, occlude the outlet and adjust the flow control valve until the PEEP is at 5 centimeters water. With either device, it's necessary to make a tight seal between the baby's face and the mask. Use the 2-hand hold on the mask and lift the baby's jaw into the mask instead of pushing the baby's head into the mattress. Do not push the mask down onto the baby's face. Do not cover the PEEP cap with your finger or squeeze the flow-inflating bag. CPAP provides continuous low airway pressure, not breaths. Make sure the CPAP is being delivered at 5 centimeters water. You may need to adjust the CPAP depending on how hard the baby is working to breathe. If the baby is not breathing effectively, you will need to assist ventilation. These are important points to remember about CPAP. The newborn must be breathing and have a heart rate over 100 beats per minute. CPAP may be helpful when a newborn has labored respirations or low oxygen saturation. When CPAP is provided, the baby does not have to work as hard to reinflate the lungs with each breath. Use pulse oximetry to guide oxygen management and maintain oxygen saturation within the target range. Insert an OG tube to decompress the stomach if CPAP continues for longer than several minutes. This is important for both preterm and term infants.
This is an example of one nasal CPAP device being used for a small infant. There are many different forms of nasal CPAP. Surfactant is a substance that is naturally occurring in the lungs. It is produced by type 2 alveolar cells in the lungs. It helps to lower the surface tension in the airways, and its main aim is to keep the alveoli open. Premature infants may not have sufficient surfactant, and this is a treatment that may be given during their hospitalization. So premature infants and low birth weight infants very well might require the administration of surfactant during their hospital time in ICU. Animal-derived surfactant or synthetic surfactant may be given. Usually what happens is we place an endotracheal tube. The surfactant is then given via the endotracheal tube. The patient is bagged. If the patient needs ongoing ventilation, they'll remain ventilated, or the patient might even be extubated after the administration of surfactant and then placed onto CPAP. The 2020 guidelines also have a section on the duration of resuscitation. It's reasonable to discuss discontinuation of resuscitation efforts 20 minutes after the birth. So if we're unable to achieve ROSC after 10 to 20 minutes of really good, adequate, intensive resuscitation efforts, then we probably should stop. The reason being is if we get ROSC after this duration, there's going to be much more severe neurodevelopmental impairment amongst survivors, and we've got a much higher risk of mortality. Even if we get ROSC for a short period, the chances are the little one will demise. So we've just spent the last hour going through the newborn resuscitation algorithm from top to bottom, and it's a really good one, this one that has been released by the Resuscitation Council of Southern Africa. Our last conversation for newborn resuscitation is a little bit more about targeted temperature management. So targeted temperature management, therapeutic hypothermia, is covered in the newborn resuscitation guidelines. And this is something that should be considered for patients that have got established or evolving hypoxic ischemic encephalopathy. So the patients that should be considered for TTM are term or near-term infants with established or evolving HIE. And this recommendation is not just for high-income countries, it's also for low and middle-income countries, depending on the resources that are available. So cooling needs to be undertaken under strict protocols where we've got a multidisciplinary team looking after the neonate. We have to have specialist level care, we have to have excellent nursing, good intravenous therapy and access, respiratory support, vasopressor support should it be required, excellent monitoring, pulse oximetry, anticonvulsants, and testing available as well. The guidelines recommend that cooling should commence within 6 hours, and strict temperature control should be maintained at 33 to 34 degrees Celsius for 72 hours. So that's 3 days. And then rewarming needs to be equally controlled over at least 4 hours. So those are the most recent guidelines that have been released with regards to TTM for neonates. We've come to the end of our talk, Pediatric Resuscitation Part 2, and this is just the roadmap for the next talk in this series, Pediatric Resuscitation Part 3, and the topics that are going to be covered in the next talk. I'm going to give you a moment to look at it before we end. So we're going to be looking at early warning scores, post-cardiac arrest care, adjuncts to resuscitation, the pediatric bradycardia and tachycardia algorithms, hemorrhagic shock and traumatic cardiac arrest, and a little bit on fluids and sepsis.